This is an overview of Chapter 2 in our Miller book regarding addressing diversity in the older adult. Through the readings and through the lecture, we want you to discuss the importance of providing culturally competent care for older adults, describe health disparities that affect older adults of different cultural groups, and identify sources of information that nurses can use to improve their cultural competence. Here's a video. And talking about cultural diversity among older adults, the increasing diversity of all age groups in the United States affects almost every facet of healthcare because cultural background significantly influences our values, our communication, our health beliefs, and health-related behaviors, as well as other aspects of communication and our personal life. So through cultural competence, we are able to recognize our own bias, immerse ourselves within the culture that we're going to care for, and this will help us to refrain from stereotypical ideas, either positive or negative against a group, and it will prevent us from making generalizations in our care. And I say this because even though certain groups might have common themes, like we think of the common American diet, right, as cheeseburgers, French fries, and high fat. We also have, each person is individualized, okay? So even though there are general themes among every cultural group, each person is unique and has their own thought processes, their own historical perspectives on life. So we want to be careful and not overgeneralizing, and that if we think again about that American diet, we want to ask the person, what do they eat? Because maybe they are vegan, or they are on a keto diet, or they prefer vegetables and a low-fat diet. So culturally competent care is a vital approach when we're working with any individual, and taking into account the older adult. Every person who's over 65 years old is not old. Every person is unique. They have their own background, and so there is a huge diversity, especially with the age of the world becoming more prominent. About 25% of the world is going to be 65 or older in the next decade. We can't just generalize people as old. We need to look at their functional ability, their spirituality, and really look at holistic care. So looking at cultural diversity specific to the United States, all of the countries, have demographic changes, which we've talked about in the last chapter about the World Health Organization, talking about the increase in numbers of individuals around the world being 65 or older. And in the United States, there also is a trend towards population aging. In the United States, looking at immigration patterns in the last 50 years, there has been a change from African Americans being the largest minority group to Hispanics being the largest minority group. And they talk about it by about 2044 that the minority groups will be more than half of the US population. So although the Census Bureau looks at race, ethnicity, and gender as their specific identifiers when looking at demographics, gerontologists are more interested in seeing if there is a relationship, or what kind of relationship is there between health and the minority status. And so is health deterred by minority status, such as ethnicity, religion, or socioeconomic status? And then how can we promote and bridge those gaps between the health disparities that we find between that relationship? And regardless of the patient, not regardless of, but in addition to the patient population that we care for, our healthcare workforce is becoming much more diverse. And this includes a workforce that might be English as a second language, so they may have limited English proficiency. And how does this interplay with our long-term care and in the communication that we provide to our patients? One of the assignments this week was the cultural self-assessment, and this cultural self-assessment is important so that we can identify our own background. What do we believe in and our belief systems? And so if we can have a sense of self and who do we belong to, how do we understand, what are my attitudes towards this and this, then we can recognize any bias that may or may not come into play when we're taking care of patients with a diverse background. In talking of health disparities can be defined as significant differences with regard to the rates of disease incidence, prevalence, morbidity, mortality, or life expectancy between one population and another. Specific to the gerontologic population, despite improvements in overall health of our older generation, older adults in a racial or ethnic minority, older adults living in rural areas, and those with low socioeconomic status experience a disproportionate incidence of illness and premature death. And although some disease patterns are related to genetics, a lot of the health disparities arise from healthcare delivery and access to care and the acceptability of care that they are receiving, such as communication and culturally appropriate care. In your book, I encourage you to look at box 2.1, which talks about the most widely identified health disparities that are going to be pertinent for promoting wellness to the older adult. National initiatives include identifying and implementing evidence-based approaches to assessment and interventions for health literacy. And so when we talk about health literacy, it's having the information that helps them understand to help them maintain good health. And so our focus when we're talking about health literacy is for health promotion. Is the following statement true or false? So we'll apply a little bit of what we learned. Health literacy is a major determinant of health outcome and a measure of quality of care. So according to the last slide, yes, it is true. Health literacy involves the need for individuals to understand information that helps them maintain good health. Nearly 9 out of 10 adults have trouble using everyday health information routinely utilized in healthcare facilities, and older adults have the lowest health literacy. So health literacy is associated with negative outcomes related to individual health and increased healthcare costs. So when we think about how we can apply this knowledge that we now have about health literacy, how can we best help our older individuals understand? We need to look at individual factors such as their cognitive level, their degree of illness, their language, utilizing every tool that we can to really identify what the barrier might be and how that they understand, and to promote education in a way that they are going to develop trust, in a way that they can understand. And then we want to educate frequently to promote adherence with the health plan. Talking about cultural competence, the definition is there on the slide for you. And overall, our goal by trying to improve our cultural competence is to progress from judgmental attitudes or from stereotypical ideas and practices to more positive approaches in treating patients with a diverse background. So performing a cultural self-assessment is raising awareness, and so having a tool related to health-related values, beliefs, and attitudes. And it's important to recognize that we may have internalized social stigmas and prejudices that are going to come out because maybe we're not educated or we don't know enough about a different culture, and we perceive attitudes and behaviors as negative or harmful. And then we kind of internalize that and think, oh, they're not listening, or they don't understand, or this is never going to change. And again, looking at the unique patient, and our overall goal is promoting good health. So we need to find those barriers and be aware of them. And in many of your cultural competence essays that you wrote, a lot of people talk about interpreter resources, and this is awesome. This is an important resource in healthcare, so that we can promote health literacy. So here's just a quick overview of some cultural groups of older adults in the United States, according to, again, the U.S. Census Bureau. So they look at race, gender, ethnicity. And so some of the major ethnic and racial groups in the United States are African Americans, Hispanics or Latinos, Asians and Pacific Islanders, and American Indians, and Alaskan Natives, excuse me. When we're looking at older adults of rural areas, we think about other groups as well, such as the homeless population of older adults, as well as the LGBTQ community of older adults, which would be, over 65. Nurses can develop culturally competent care by educating themselves about cultural traditions of these adults that are prevalent in their community. So this case study comes directly from page 28 in our text. It talks about Mrs. A, an 81-year-old African American who lives with her daughter Mildred and teenage great-grandson in a 2-bedroom apartment in a large metropolitan area of Ohio. Looking deeper, Mildred, the daughter, works as a nursing assistant in a nearby nursing home and often works double shifts. Mrs. A was born in Alabama and lived there until 20 years ago when her husband died, and she moved in with her daughter, who lived alone at the time. 7 years later, Mildred took on responsibility for raising her infant grandson, who is now 13 years old. So just looking at this case study, when we're using our nursing process and we're starting to critically think about what our goal is, right? It's finding risk factors, identifying barriers to promote health. In this first little part, what are some things you might notice that would have a positive or a negative aspect on Mrs. A? What things stick out to you? And we'll talk about those in a couple slides. Going forward, Mrs. A has glaucoma, arthritis, and hypertension, and she had a stroke several years ago. She admits to having a little problem with my memory, but Mildred says she remembers what she wants to remember. Mrs. A takes an over-the-counter analgesic as needed for her arthritis and has 2 prescription meds for hypertension. She also uses prescription eye drops twice daily. Mrs. A has her blood pressure checked by the parish nurse about once monthly. She sees a doctor and nurse practitioner at a neighborhood clinic for checkups about twice yearly. The parish nurse often tells her that her blood pressure is a little on the high side and encourages her to see her doctor. But Mrs. A has difficulty getting appointments because she depends on Mildred to take her there. Mrs. A is about 30 pounds overweight, and she walks very slowly. When she is out of the house, Mildred provides a supportive hand to assist her with steadiness and mobility. Mildred shops for groceries, but Mrs. A prepares most meals for the family. So again, thinking about cues, recognizing again, barriers. What are some things that we're seeing here? And I might have jumped the gun and highlighted some things already, but what are some things we would like to focus on when we bring Mrs. A in as the parish nurse, talking about health promotion? What do you see so far that you'd like to focus on? So going through again that case study, how might Mrs. A's living arrangements influence her health and functioning both positively and negatively? This can come to what kind, so the living arrangements is the apartment she lives in, the metropolitan area, the people she lives with. So what would be positive and negative about those things? One example of a positive would be that she has family support. Mildred provides groceries, provides assistance, and is there to help her with her blood pressure and help her manage her medications. She has the 13-year-old great-grandson there that can be a wonderful support for feeling needed, feeling part of the family, for passing down traditions. Some negative impacts might be the physical arrangement. I'm wondering, how do they sleep in a 2-bedroom apartment? Who gets the couch? Does someone share a bed? I think of, fire code, mobility, and comfort in that situation. Okay, and there's others too, so those aren't the only two examples. What factors are likely to influence the kind of health care Mrs. A receives? And so one major influencer that I saw with receiving the kind of care is that Mrs. A depends on Mildred to take her to the nurse practitioner appointments. But luckily there is a parish nurse, right, who often sees her. And so when we talk about community nursing and things we can do to promote health in our community, that parish nurse is a nice, oh, what do I want to say? Adjunct provider to educate. But anyways, going back to the influencing, what's likely to influence the kind of care is the access to health care. Can she get there when she needs it? If you were the parish nurse, what actions would you take to decrease health risks and promote quality of life for Mrs. A? And so kind of alluding to thankfully she has a parish nurse. So how often does she see that parish nurse? We don't know. Is it every week when she goes to for devotion? I don't know. Hope, maybe it is. But regardless, we know that she sees the parish nurse, and as that parish nurse, what can we do? We would really want to ask those questions. Are you able to fill your meds appropriately? Do you ever run out? Do you take them as prescribed? So we know that she's prescribed meds, but does she actually take them? Does she have access to them? Does she know what they're there for? Because education and access are going to be two huge influences on our ability to adhere to a health regimen. And what additional resources could be used to improve Mrs. A's situation? One might be home health care. So when we talk about in future chapters about the delivery of healthcare and the different settings that we deliver, home health might be an option for Mrs. A because she truly cannot get to her appointments without the assistance of another person. So having a nurse come into the home to, assess living condition, assess the ability to take meds, and do functional assessments might improve Mrs. A's situation. Thank you.